late, but why not have some technical issues to begin the day. So hopefully the rest will go more smoothly. So we have a very exciting webinar today, particularly exciting one. By way of introduction, my name is Kathleen Kieran. Along with Dr. Peter Asante, I'm the co-chair of the Equitable Care Work Group for the Washington chapter of the AAP. And our Equitable Care Work Group is really charged with making a toolkit that helps providers and everyone who cares for children, as well as clinics, determine better ways to actionably identify opportunities for equitable care and to implement those. And so this webinar is the second in a series. And it's entitled Physical Space Within Clinics and Hospitals. Go to the next slide. By way of our introduction, we thought it was particularly appropriate for this topic to acknowledge the lands that we're on. We are currently on the Yakima tribal lands. For those of you who live in Washington or are aware of Washington state geography, you'll notice that Yakima is spelled differently when we're talking about the tribe than about the city. And this historically goes back to the 1855 treaty with the Yakima. There are 14 bands and tribes that ceded over 11 million acres to the United States. They're listed all here, and you can also click on this link to get a little bit more information. However, what I think is really important here is that you can see the amount of land that was ceded to the white man by the Yakima Nation, and the darker area that's down in the south central part of Washington is the current reservation, the Yakima lands today, the Yakima Nation. All right, so we'll talk a little bit about the Equitable Care Toolkit background. Thank you, Dr. Bell. She commented that she loved our land acknowledgement. We'll talk a little bit about the physical space section, and then we will turn it over to Ms. Thorson and Dr. Eby for designing at the edges, making a case for why representation matters. So next slide. Okay, the toolkit background. As I alluded to earlier, the Equitable Care Work Group was charged with putting together different ways for everyone who cares for children within Washington state, and indeed within the whole WWAMI region, to look at ways that we can provide more equitable care. And so we tried to make this accessible to everyone in the office, everyone who cares for children. It wasn't designed just for physicians, just for nurses. It's designed for the people at the front desk, medical assistants, and everybody who's involved in the care. So our goals are to provide equitable care, to make healthcare more welcoming and responsive to families of color, to deliver high quality care to the diverse patients and families within Washington state. And then it's actually, it is live on our website right now. So you can click on that. It's under wcap.org/physician/equitable care. And the link is in the chat from Ahmad. Next slide. Here are our equity work group members. As you can see, Peter and I are the leaders, but we have an amazing group of people who applied to be part of this, and they have done a phenomenal job. We truly could not ask for a better group of people. Peter, do you want to go from here?
Yes, I can take over. Sorry about that this morning for all the technical difficulties. It sounds like we're still in 2020. So thank you for joining us this morning. We are going to be talking a little bit about physical space and how to create physical spaces that are inclusive and welcoming to the families that we serve this morning. The physical environment patients and families encounter when seeking care has a multifactorial impact on their experience. Not only is it relevant to the healing process and overall patient well-being, but it also serves as an entry point for the patient-provider relationship, which is fundamental to patient outcomes. Healthcare facilities serve a diverse patient population with unique and variable needs. And as a result, there is no one-size-fits-all prescription for how to design a welcoming physical environment for all. In fact, decisions with the intent to welcome one community might inadvertently impact another. In the toolkit, we hope to guide providers and clinics through a process of exploring the question of clinical space design as it relates to your own community and physical space. The intent of this toolkit is to promote conversation and change from a variety of levels, as simple as the imagery, labels, and handouts on clinic walls to overall assessment of clinical layout, design, and workflow. This toolkit provides suggestions for how to start a collaborative process of clinical space design with specific ideas to consider to promote an inclusive and welcoming environment. Next slide, please. Perfect. And before I introduce our incredible speakers this morning, I just wanted to put a reminder out there that we have 2 more webinars in this series. The next one will be September 29th on providing safe and effective quality care. And the last one will be in December, promoting equity, diversity, and inclusion in healthcare organizations. And so expect more emails from us in the coming months, but we promise we will centralize the madness around the time of these webinars. Next slide. So I would like to introduce our presenters this morning. And Carrie, if I get it wrong, I really apologize if I said your name wrong, but it's Carrie Thorson. She's a principal of ZGF Architects LLP with over 17 years of experience leading the planning and interior design of many of the firm's large, high-profile healthcare projects. For Carrie, every project is an opportunity to change how healthcare organizations approach the delivery of compassionate, healing, and community-focused care. One of our favorite parts of working in healthcare design is speaking to patients, families, and staff about how new projects can improve their experience. Combining these insights with each client's unique culture, aspirations, challenges, and needs, Carrie always strives a balance between the functional requirements of the project, community context, and therapeutic elements of nature to support the healing environment. In 2019, she was recognized among building design and construction's 40 under 40. And in 2017, she was recognized among Healthcare Design's HCD 10 as Interior Designer of the Year and as Healthcare Design Leader. Our second talk will be from Douglas Eby, Vice President of Medical Services for South Central Foundation's Malcolm Baldrige award-winning NUCA system of care. Doug is a physician executive who has done extensive work with the Institute for Healthcare Improvement and other organizations around the triple aim: accountable care organizations, patient-centered medical homes, whole system transformation, workforce, cultural competency, health disparities, and other topics. His speaking and consulting includes work across the US, Canada, and portions of Europe and South Pacific. Doug has spent more than 20 years working in support of Alaska Native leadership as they created a very innovative integrated system of care that has significantly improved health outcomes. Doug received his medical degree from the University of Cincinnati, Ohio, and his master's in public health degree from the University of Hawaii. And with that, I will stop talking and I will let Carrie start. So thank you guys for joining us this morning.
Thank you so much for that introduction. Let me share my screen here and we'll get started. So today I want to talk to you about designing at the edges and making a case for why representation matters. So many of you maybe have been a part of a lean healthcare design process or process improvement work where we talk about the 80-20 rule. We often design using this rule so that we're making sure we're providing care for the 80% of your typical day, your typical patient population that comes through the door. And what that does is that it allows for the 20% of unexpectedness to happen throughout your day or unintended visits that come throughout the day. And so we use this rule a lot when we're doing design. But when it comes to designing for equity, we cannot afford to exclude that 20%. At any point in time, any one of your patients can fall to that edge of that 20%, whether it's their gender identity, their ethnicity, their disability, their age, or the illness that brought you to see them in the first place. At any point in time, we need to make sure that we're providing care for all of your patients. So there's no one size fits all solution to this, but by opening up the design process to more diverse voices and truly engaging and understanding the patient populations that you serve, as an organization, we can make design decisions that acknowledge the needs of the 20% while still functioning for the 80%. So often as designers, we're challenged to make as much flexibility into the space as possible because healthcare serves a wide range of patient populations, but they all have very specific needs. So we need to try and balance the extremes in design. But as Peter mentioned at the beginning, what works for one patient might have unintended consequences for others. So unlike other aspects of design, this 80-20 rule just doesn't apply. So we need to design spaces with greater flexibility, but without losing sight of the bigger goal to ensure that every patient is cared for. So first, we need to identify early on in the design process representation from all user groups and community members that will be impacted by our projects. So representation from all user groups and community members. Without their input, we don't know what works for one group that maybe won't work for another. And when it comes to designing pediatric facilities or programs, this becomes even more important and more complex. So as Peter mentioned, I've been almost working in the healthcare design field for 2 decades now. In the past 10, I've really focused my career on pediatric care. And how we engage and understand your diverse patient population truly does lead to more equitable and inclusive design decisions. One of my favorite examples of this is we were designing a critical care tower in another part of the country, and we were having a workshop, and we had staff involved, and we had our team involved, and we had leadership involved, and we finally were getting families involved, and we were finally getting to be able to talk to patients. And one key patient that I will always remember was a young teenage boy who wanted to talk about the position of the bed in the room. And he had spent years with a critical illness in the hospital with his parents and his providers on either side of that bed, talking over him about the next steps in his care. And his one goal for this patient room tower was that the bed could be positioned in a way that the patient could see both the provider and his parents and look them in the eyes and be able to be a part of that conversation while they're making critical decisions about his care and see the reaction on their faces as they talked about next steps and made sure that he was included in that design process. Because of that, we changed the way we thought about the space, and it became an even better design solution that was more beneficial to everyone involved. Just to stress this point a little bit more, another tool that we use when we're looking at this is Maslow's hierarchy of needs. What I want to point out along the side here is this toolbar that says basic needs up into a better user experience or a higher standard of care. And we really don't start to tip that over to a point until we get to this point of love and belonging. And I want to point out as we work our way up the tower to this higher standard level of care that once we meet our physiological needs, the next step in making sure that people feel safe in their environment is meeting the diverse needs of our community and providing universal design. Another moment that I want to point out here is this ability for choice. And we all know that in healthcare, so much choice is taken away from us. And so it's key to our design process when we're creating new spaces that we allow for choices to be able to be made. And I can't stress this enough that we really don't start to strive to providing better care until we create a supportive environment that makes everyone feel welcome and like they belong. So Peter and Kathleen did a great job of outlining the toolkit. And what I love about it is that it gives really simple examples of how you can create a physical environment that involves more equity and more inclusion to your patients, your families, and your staff. So the 4 things that I want to talk about today is how we can encourage more engagement throughout your process, how we can help provide choice in your facilities, improve accessibility, and then how we can incorporate representation into our physical space design. So as I mentioned, this really involves engagement. Community engagement has been a hallmark of the design process, and bringing diverse voices and input and feedback, it ultimately shapes the design of each new project and reflects the community. So I've worked across the country, and while there are lots of similarities across healthcare organizations and across groups, each organization and each city that I've worked in has a different set of unique needs, and we want to engage everyone, even from the beginning. So when you're able to start a project from new, what I want to talk to you about today is what that process looks like and how we can reach out and get feedback from more patients and families and staff. And that means bringing everyone to the table. So when you're talking about your staff, having your providers there, your nursing staff, your environmental service staff, everyone is a part of that process to make care. So we have workshops, we have charrettes, we have places around models where we're really incorporating that feedback and bringing everyone's voice to the table. And it's our job as designers to synthesize all that information so that we can balance those extremes and make sure everyone feels included. So I'm going to walk through a few other examples of how we've been able to do this. Some of the best user engagements we've had is going into the schools that may be a part of your engagement process and reaching out to the patients that your organization serves. So we've had design charrettes with patients about, even choices from color palette to animals that they want to see in wayfinding to art styles that respond to their unique needs and things that they understand from their community. A couple of other key things that we've done as well, what this pandemic has taught us is that we don't always need to be in a big room together. While there's lots of benefits for that, and we can't wait to do that, we've also been able to send out surveys and design ideas to more families and to get a bigger outreach of being able to include it. So this is an example of, we put together 10 images. We asked patients and families to select their top 3 and really talk about what they wanted to see in their environment in order to make sure that they all felt included in the design. There are simple things that you can do to encourage engagement throughout the course of your day. If you can't form a family advisory committee or a council, just even asking patients to fill out email surveys by asking simple questions, we get a lot of really great feedback. This example happens to be from an autism and behavioral health clinic that we worked on, and we asked a simple question to their patients and families: what would support your child and your family during their visit? And we got pages and pages of responses that greatly impacted the design decisions we made and the processes that they put in place to be able to activate this clinic. One key example that I'll point out here is by asking the simple question, they said, you know what, even though we knew we were going to maybe get a diagnosis of autism that day, the moment the provider told us that, it instantly changed our lives. And what we thought was going to be our life going in one direction, it completely changed. And we needed to build in time for patients and families to be able to digest that news and have that, and how important it was that this space made them feel like they belonged and that they were welcomed there. A few other things to consider when we're creating these engagement choices for your patients and staff members is social and economic considerations. We can't always have our families, though we've been pretty successful, of course, the past few projects at every single one of our design events. Maybe they're single parents, they work during the day, they can't come to our design events. So we schedule after hours community events where we open up the doors for them to be able to come. I've had healthcare organizations actually pay for childcare so that they can really hear from the voices of the parents and families. We've also opened up community events in the evenings where kids can come, and we have activities for them to do too. We have coloring activities where they can provide input into the patient room and design and have them play around with some of the pieces so we hear in their impact as well. And one thing that's also key in this consideration is making sure you're reaching your demographics. So understanding where all your patients are coming from and what ethnicities and cultural considerations need to be considered, and reaching out to those specific groups in particular if they're not coming to you. So as a couple of examples, we've worked a lot with Seattle Children's, and we've worked with the Duwamish tribe that's local there to talk to them about their specific needs. Work we've done up in Saskatoon and that peninsula, we've gone out to the remote communities to gather feedback from their group to make sure that when they need to come to the hospital, that they feel welcomed and cared for and understood. So I can't stress enough how important it is that we bring people together at the table. And there's so many different ways that we can really reach out. And this pandemic has taught us that surveys and chats and these forums that we're able to create together, we're actually hearing from more people and making everyone feel more comfortable. So we'll be continuing to do that in the future. So let's move on to a couple of case studies so we can show how some of these community engagements have really impacted our project. So first, we're going to talk about choice. So one of the most important ways we can make people feel included, that there's equity in that, is by providing choice. And a simple way to be able to do that is by thinking about the furniture that you're putting in your waiting rooms. So if you don't have a big project, but maybe there's smaller ways that you can actually update your project in your spaces. So these are two examples of furniture choices that we've made to make people feel included. The size of furniture, the scale of furniture, the choices that we're making to allow people to have a little bit of a say in where they go in your waiting spaces and in your welcoming environments. Making sure that we have love seats and sofas to accommodate a bariatric population without only having one bariatric chair in the waiting room that says, oh, this chair is for this certain population. There's lots of tricks you can use to be able to make people feel included without excluding them in the process. But having this variety and this choice makes everything a bit better for that. And it's a simple, small way that you can improve and include people within your space. Another simple example is signage. So when it talks about gender neutrality, a simple tool and trick that you all could use as part of your clinic design is simply changing the signs on your family toilets or your multi-stall, multi-use toilet rooms to a gender neutral sign. It automatically makes people feel included into the space and that they can use it without feeling judged or being put into one identity or another. And it's a simple, really easy thing that you're able to do almost immediately within the space. Next, I want to talk about choice within our patient rooms. So this is the University of Iowa Steadfast Children's Hospital. And what we did within the patient room to help patients feel like they had some control and some choice over their environment is the light fixture that you see along the side here. The patients have control of. They can pick the color, they can turn it on and off, they can make it be whatever they want in the room and have a little bit of say over their environment. Another really conscious choice that our design team made was keeping the footwall very neutral so that they could add their own elements from their home so that they could make that space feel like they belonged. Places where they could display items from home, pictures, cards, toys, that they could really create their own environment. This client happened to go even one step further with their controls and their technology that allowed choice for entertainment that was being able to be shown, choice to invite child life up to provide activities for the kids to do, food choices that they can order throughout the day as well, and even choices about bringing aromatherapy and other aspects in the room that really provided that ability for them to create an environment that made them feel comfortable and like it was a space for them where they belonged. Next, let's move on to creating accessibility. And the case study that I want to share here is the new building that we're doing for Seattle Children's Hospital called Building Care. It's the new diagnostic and treatment center, but it also happens to be the new front door for the hospital. And our team spent a lot of time talking about what this wanted to be. There's a trend within design and healthcare that we put big feature stairs in our lobbies to help promote health and wellness. But when we met with an extensive user group, one of the first things that our patients and families said is that, you know, the stairs are great and we love that it creates this connection and that it provides this accessibility and promotes health, but so many of the kids that were going to come through this front door are never going to be able to walk up that stair, and we don't want the first thing for them to see is something that they won't be able to do. So intentionally, a way of creating a more accessible space here and making them feel included was by removing that stair from the space. Another thing that we made sure to do was provided seating alcoves that left spaces for wheelchairs and strollers and helped give space for people to move freely throughout the lobby. Another feedback that we heard is Our patients are coming from all over the state, sometimes out of state, in order to receive care here. And the journey just to get to the hospital can be really challenging for families. And we wanted to provide them, as soon as they got in the front door or up from the parking garage, accessibility to a bathroom that had changing tables for both our smallest patients, but as well as adult-sized changing tables for our larger patients that had mobility issues, so that they could gather themselves and get themselves together from a long journey. Also, these private little seating areas where they had a moment just to say, okay, we made it. Now let's do what our next step is in our journey here for care. A couple other examples from this project is construction. We're meeting building types. So now we had a 3-foot high difference from our new building to our existing building. And instead of putting a stair with a small ADA accessible ramp next to it, we made a large ramp that has a very slow slope to it. So no one would even know that they're walking up towards the ramp to be able to get there, but made it a part of the experience and a part of the journey, and didn't put any barriers for anyone that had any physical disability from getting from one space to another. So small choices that we made to make people feel more included. Another really small example here is we created these alcove nooks, reading nooks for kids. And sometimes you'll see benches in there and spaces that kids can crawl into. But we wanted to make sure that any child with a disability was able to wheel in there and have the same experience as a more mobile child, to be able to use those spaces and make sure that they were all accessible. So the last thing that I want to talk about is putting representation into your hospitals and your clinic spaces. As part of this, another example of inclusion is as simple as art choices that we make. So often in children's hospitals, we actually use nature and imagery to be able to connect to kids and have them tell stories. One thing that we do very intentionally at Seattle Children's, and a few other examples that I'll show, is we make sure that we're showing different family units, we're showing a diversity of species, we're showing animals together that can help support each other, that look different from one another, so that maybe kids can begin to see themselves or see their family examples or see examples of how they might not look like their brothers or sisters within all of the artwork and the choices that we're putting together. We've done this across a variety of children's hospitals throughout the country to really make sure that everyone can connect to that. And we've done activities with kids that it's animals and examples from their own communities that they really can respond to and relate to, that make them feel welcome and at home. The Jim Patterson Children's Hospital up in Saskatoon, the animal choices that we made had different cultural impacts depending upon the ethnicity of the tribes that we were responding to. So we were very thoughtful, even at that level of detail, of what types of animals we should show, and making sure there was no cultural issues or anything that was sacred as we went through and chose the artwork for that space. This also extends into our faith-based spaces that are so important to a healthcare organization. In Seattle Children's, as part of building care, we also needed to relocate the chapel. And the most important thing to the chaplains that we worked with there and their spiritual care group was that every single faith felt welcomed into the space. And so there are 5 panels here that represent the 5 primary faiths that they see at the hospital. And they reached out to each of those different environments to create panels that had symbols that were important to each of those faiths or each of those communities or cultures. But we did it in a way that everyone felt welcomed into that environment and felt like they had a place. And also, when we're thinking about that, making sure that we have private spaces for prayer and meditation that respond to the cultural needs of the communities that you're serving. So little ways in which you can make sure that everyone feels included into that space. So just in closing, I hope what you've learned today is that more than an outcome or a solution, designing for equity and inclusion, it's a process, and that any institution, large or small, can make a conscious effort to improve equity and inclusion. You don't have to build the new facilities. These small changes of furniture, signage, artwork can have a big impact in making everyone feel welcome and invited into your space. So thank you so much for having me today, and I look forward to any questions you might have in the near future.
Thank you so much for that incredible talk, Carrie. And we will, please post your questions in the chat or send them directly to Kathleen or me. Our next presenter is Douglas Eby. Take it away.
Peter, before you go, could I ask a quick question about this talk? I didn't put it in the chat just because. Carrie, I'm just wondering, you talked a lot about the designing, and I know that in the current climate, healthcare cost concerns are significant for many hospitals. I worked at Iowa actually when they were building their children's hospital, and I know they were thinking about that. I'm just wondering if you can comment on how much more or less or the same it is financially to provide healthcare settings that are inclusive versus not inclusive. And there's also a comment from Doug about making them easy to change. Just what's the, I know, as Sarah said, there's a lot of things in the toolkit, but from a global standpoint, from your perspective, if I come to you and I want to make an equitable space, are you going to tell me this is the budget and it's going to be way out of here, thinking of it from like the House Hunters HGTV?
No, no. Actually, I think that it's not more expensive. A lot of the times in terms of what we're doing, the choices that we make are all budget choices. But when we're talking about inclusion, there are things that are able to, we can design that in, and it doesn't have a higher cost or a higher premium. I would say the higher cost or the higher premium is actually not designing for inclusion, and all the patients that you're missing or having to make special accommodations for when you're into that space. So I think it's just being really thoughtful about the choices that you make and making sure from the beginning that you're doing that. So actually, in a lot of ways, by taking out that feature share, we saved money in making that space feel more inclusive and more inviting. And there's trade-offs throughout the design process to be able to create that. But no, if you come to me and you say you want a more inclusive space, it's not going to be more expensive from that way. You know, the aspects and the design elements are the same. It's just how we think about simple things and simple choices that really change that. You still need to provide 20 seats in the waiting room. And if we provide 20 different seats in the waiting room, that's not going to change your cost dramatically, as a really probably simple way of explaining that. Does that answer your question, Kath?
Absolutely. Thank you. Awesome. Thank you for that, Carrie. That was a great explanation. Douglas, you're up.
Okay, so obviously we are going to run out of time way before we run out of topic. And so I'm just going to throw a whole lot of stuff at you. And then if people are curious to connect with us more, go to our website, connect through. We have a whole learning organization. There's a couple of our folks, Erica and Tanya, online during this presentation. Happy to connect with people more if people are interested. All right, very quickly, it's been my incredible privilege to help support Alaska Native people, and they're owning and driving the complete reinvention of an entire healthcare system over the last 25 years. And there's just a ton to the story, so I'm just going to hit a couple highlights and get right into the space conversation. Next slide. So our whole, who's going to move the slides? Hello?
I think they're advanced, Doug.
Okay. So our system has been customer owned and customer driven now for over 20 years. The slide that just jumped through and disappeared shows that we've made massive improvements in decreased high cost utilization, tremendous improvement in health outcomes. It's a geographically and lots of challenges to the environment and the community. And despite that, we've won all these big awards and completely changed health outcomes and health direction and trajectory, because the system is community owned, community driven, community designed. And those of us in leadership are just here to support and follow the lead of what community members want. Next slide. So the whole system's built upon this idea of customer ownership and relationships. So all of our messaging says that we're here completely to respond to when, where, and how people want healthcare. Healthcare tends to be very professional centric and institution centric and facility centric. And that's just completely ridiculous. Healthcare ought to be your partner when, where, and how you want to be partnered with. So for us, for over 20 years, you've been able to have a relationship with people who know you in a first name basis, have all day, same day access to them for however you want to connect, email, phone, text, or in person. This has been true for over 20 years. And what I'm talking about is outpatient and clinic space design, not hospital design today. And the entire system is built around the idea that we are continually present. We weave our support services and knowledge into their lives on their terms, when, where, and how they want connectivity. And even pre-COVID, about 2/3 of our encounters were virtual. Once you establish a relationship, you really don't have to make people come to your institutions all the time for everything. Your job is to make yourself available to them when, where, and how they want and need you to be available. So this is all built on a very sophisticated platform of operational principles, core concepts, and everything we do is based upon these principles, which came from the community about what they want. Our system, by the way, now is staffed over 60%. About 2/3 of our staff are Alaska Native people. 3/4 of our leadership are Alaska Native people. Our board, our CEO and senior executive leadership are almost entirely Alaska Native people. It's truly a customer-driven design system. Next. It turns out it works way better. Less cost, happier people, better health outcomes. We think that facilities, the community should drive program design, and program design should drive facility design. Too often facilities are designed by design firms and senior executive leadership who have the power and the money, and that's completely ridiculous. This needs to be driven from within the community. And if you don't know this, the single biggest variable related to health outcomes at an individual level is self-confidence. The more someone has self-confidence, the more they do to life. And the less self-confidence they have, the more life does to them. And so it's extremely important that everything we do, from our waiting areas to the facility when you approach it, to the spaces in which we encounter people, to how we design program, should promote pride, honor, dignity, respect, and self-worth. Because if you can change those and improve those, you're actually going to have a bigger outcome on health than anything else you could possibly do. So having gorgeous, fabulous, comfortable, inspiring physical spaces is an extremely important part of this journey. Cost was already brought up as a question. We spend about 20% more on especially public spaces where the public are going to be present than we would need to, because pride, honor, dignity are very big deals. Alaska Native people for too long put up with second rate, sort of that Native place over there. And instead we want to be the most beautiful, inspiring facilities in any given community. We want people when they go by to say, oh, that's the Native place, as opposed to, oh, that's the Native place. And so we intentionally spend a lot more on comfort, design, inspiring spaces and public spaces and so forth than most other institutions do. Next. So workflows are very important to understand. Historically, and still most places, everything goes through the medical provider. Next slide. We instead think parallel processing is the way to go, where all of our different staff work at the top of their license and they can all provide whatever it is that the person needs, and we connect people. Every door is a right door, but you connect to the people you know, which is 2 or 3 people who know your first name, who you know them, available to you 5 days a week, all day, every day, any way you want to connect to them. And then they'll pull in other resources and other people. Next slide. So this is the very simple design diagram. It's way more complicated, sophisticated, but the customer owner, we refer to the people who come for services as customer owners, because they actually do own their own journey, and they actually do own the entire system, and they own everything about what we do. And they are customers who have choice and can make choices all day long. In fact, they do make choices all day long, whether they take their meds, whether they don't, what they eat, tobacco, alcohol, exercise, all those things are under their control. We have very little control. Our ability to make a difference is only based on our ability to influence and inspire. And that's pretty much all the control we have. And so the whole power way we do things has to be completely rethought. So the customer owner family in the middle, there's a primary care team, that the people they know on a first name basis. And then there's all these co-located people. So there's tons of behaviorists and dietitians and psychiatrists and social workers in the space, just available. They don't have separate schedules. They don't have separate rooms. They're just available to interact and support and be part of the people available. And then the next layer out, the dark blue circle, there are other people. So there's embedded psychiatrists, chronic pain experts, HIV experts, physical activity experts who are just all in the physical space with nothing else to do other than support the interactions in real time. And there's a ton of sophistication about how this is done in the physical spaces. We've taken a system over 25 years, reoriented everything to be about the people in the middle and then pulling resources towards them rather than sending them around to other places in order to get what they need. Completely ridiculous. The center of excellence approach where you have to go 20 different places to get 20 different things is completely ridiculous, ineffective, and offensive, actually. Next slide. So we've done a ton of behavioral health integration. Next slide. So basically we have behavioral health everywhere. In fact, if we were really designing on a blank slate, we'd build a behavioral health program with a little bit of medical advice, because that actually is the platform, is a relational platform helping people with the struggles of everyday life, no matter what their physical realities are. Next. All right, so spaces, this is the front of our main primary care center in Anchorage. We have something like 57 facilities now, I think, and they're in all kinds of different communities, from villages to small towns to bigger cities and so forth. But a lot of our design elements involve a lot of glass, a lot of light, a lot of natural elements. The idea is that all of our spaces feel like Alaska Native spaces, but not any particular tribe. Because what we don't want is one tribe to be the host and the others to be the guest. We're based in the city. All the different tribal groups are here. So we're really intentional about our spaces feeling comfortable to Alaska Native people and all people from Alaska, but not specific to a culture, because then someone becomes the host, someone becomes the guest, and that is not our goal. It should be everyone's place, have a deep sense of ownership. Next. So a lot of our spaces, also a lot of what Carrie was talking about. So the idea of respect and honoring and access. So like in this picture, the top left picture there is the front, is the way our front desk look. There are high, tall surfaces for tall people, lower surfaces for lower people. So whether you're tall or short, in a wheelchair or not, everyone has access to whatever surface it is they need. All of our front areas are open and welcoming. There's none of this, we don't like you, we don't trust you, a barrier in between. That's ridiculous. But we do have safety and environmental controls and infectious disease things built into the spaces. I don't have time for all the details today. It's all very intentionally built though. And as Carrie mentioned, stairs are better than elevators. And so we make stairs the easy option in every single space we design. And about 70 to 80% of the traffic in any of our buildings uses stairs rather than elevators because of where they're placed and the fact they're very attractive and how they're designed. We also are in an Arctic, subarctic environment. And so we've built a lot of passive light things. We have concentrated beams of sunlight that hit mirrors and prisms at certain days and certain times of the year. And so there's a very active connect to the natural environment thing built into the light and the spaces and how we do all of that. Again, no time for all the details today. If you're interested, get a hold of us. Lots of cool stuff to be done with light. Next slide. In the bigger buildings we have, so our bigger clinics are always huge atriums and common spaces. We think we are a community center and a community gathering place in addition to a healthcare facility. And so we build that into the space. So our lobbies are huge. They're comfortable. They can be subdivided. They can be used for weddings, funerals, potlatches, all kinds of community events in addition to the processes of the day-to-day clinical interactions. And there's a ton of stuff about what we've done in those spaces. And the window that's shown here right outside that window is a healing garden. So there's like 25 medicinally active plants growing there. We teach people how to identify and harvest plants as just part of the everyday process we do. Next. Again, the lobby, colors, light, textures, things that evoke. This is an Alaska place and a tribal place, but without being tribe specific. Next. Again, stairways, very intentionally built, and gathering places, easy ways to talk and connect to people while still being safe and private and all of those other things. Next. Textures in the floors and the walls and the signs. Again, there's natural elements. All of these designs come from nature in Alaska. And again, trying to get things that are across different regions of Alaska. Alaska is huge, and in the city, people come from all different parts of the state. We also have a great deal of intentionality about where and how signage is created and so forth, so that it's intuitive and natural and easy to use. So for example, when you come out of the elevators, there's no signage. You are forced to go in the direction out to the common area, and then there's where the signs are. So you can see and feel where you're going instead of trying to figure out on a map, which only works for a tiny percentage of the population. Next. We also, as I said, make our buildings inspiring. When I arrived 31 years ago, we were in old crappy buildings that were sort of, second rate. And that sort of messaged, hey, you're Alaska Native, you're second rate, you get second rate services. And that is not okay. So all our buildings are gorgeous, beautiful, inspiring. In fact, we aim to have the most beautiful buildings in any community we're in, so that people go, wow, that's the Alaska Native place. And then also people who go there say, I'm worthy of this, my people are worthy of this. Isn't it super cool? All right, next. So we also then, in terms of the interiors, awful lot of open, dynamic, integrated care team spaces. About 15 years ago, we de-officed everyone. So in all of our buildings, there's not a private office for a single person. There's no doctor spaces. There's no doctor's offices. There's no doctor lounge. The senior executives just have little desks that go up and down. You can sit at them, stand at them, but there's like 15 of them in a shared space with a conference room in the middle. So myself, senior executives, we don't have offices. We don't have private spaces. We de-officed everyone a long time ago. The idea is if you're managing something, you should be physically in the thing that you're managing so you can feel what's happening minute to minute. And if you're providing clinical services, it should be in a team, integrated team environment. Next. So one of our first things was we put offices right in the middle of clinics. And so we took exam rooms, took out a wall, made offices, and put case managers, care coordinators, social workers, behaviorists, and providers mixed right in the spaces. We don't do this anymore, but that was our first attempt. It was a great improvement over where we started, but we don't do it anymore. Next. The evolution went to this then, where you had all of the clinical spaces in the middle with all of the office spaces in the perimeter. So everyone had windows and access to outdoors and so forth. This is sort of the on-stage, off-stage idea. The public comes from the front, the staff come from the back, they meet in the clinical areas and then sort of go. It's the Disney on-stage, off-stage idea. Again, an improvement from where we were, but we don't do this anymore either. And part of the problem here is scale. Like this is a huge clinic putting 150,000 visits a year through this one big clinic. And so when we renovated it and built a new wing, we right-sized all of our spaces. So there's a lot to know around the sociology of the workplace, which I don't have time to go into here, but up to 15 people in a workspace can work in a family environment. 15 to 70 is a team environment. Over 70 is a bureaucracy. Our goal is to have staff between 50 and 70 people in any given clinic. And so as population increases, we add clinics. We don't create bigger and bigger clinics. There's 15 minutes of content there I don't have time for. It's just extremely, extremely important you understand it. Next. So this is what we did here. We put the managers at the front desk, keep going, but we don't have front desks anymore like this. And we don't have, we eliminated all nurses stations, eliminated all private offices, just a whole lot of things. This is the group sociology business here. Next slide. What we do now is you have a front desk in the front left-hand corner in a waiting area, and then you come into what's a whole bank of talking rooms with no exam tables, and then you turn the corner, and then there are exam rooms with exam tables. The staff are all on the far left of this picture. It's a big open space, and they align with the hallways. These are in this picture that just popped up is the integrated care team space. Again, all open environments, carefully organized, so the provider and the CMA are going in and out of the room. The case manager support are primarily doing virtual things and never leave their desks. The behaviorists, dietitians, social workers are all integrated and mixed in among these different teams. There's line of sight. Everyone can see everyone, but the spaces are broken up. So it's not just some big mass of humanity. So incredible attention to the detail, the textures, the colors, the light, the ceiling height, all of those things. The central corridor between two clinics, there's an East Clinic and a West Clinic back to back. On the central corridor are all the procedure rooms, the clean and dirty utility, the EKG, the nebulizers, all the things that clinics need that can be shared between the two clinics. The picture just popped up. That's the front desk. These are group rooms for group medical appointments or meetings with the community or team meetings for the staff. Next. Inside the clinic, there are seating areas, lots of natural light. You go from public to semi-public to private. There's a great deal of messaging in the space. That desk right there in the open space, that's the manager. The manager's right physically in the clinic space. They don't have an office where they can go and hide. Next. Break rooms and so forth, keep going. We're almost out of time. The final phase I'm going to show you here is our most recent, which is our big clinic in the Mat-Su Valley, Wasilla, Palmer area. Next. In there, we created integrated rooms. We made the exam rooms just slightly bigger, but now they have talking room and exam room in the same room. They're hybrids. So in our most recent clinic, 80% of the spaces are hybrid rooms and 20% are talking rooms. And basically no room is created that can't be just a talking room. The idea you have to be naked sitting on an exam table to have a conversation about your health is offensive, paternalistic, professional-centric, facility-centric, and dumb. Most people should be interacting at a human level, sitting, talking with each other, and the exam table should only be a last resort if you absolutely have to. This building being shown is the big, beautiful building we opened in the Mat-Su Valley a couple years ago. Again, a massive lobby using light and wind and direction and views and so forth, all built in with intentionality, play area for children, gardens, fire pits, all kinds of things built into the space. Next. And then this is interior shot of the lobby and some of the panels. The panels include language and pictures of history and current things and subsistence life cycles and healthy eating and that kind of stuff. Next. In all of our big facilities, we even now have learning kitchens where you can prepare snacks and food in real time with people while they're there for visits. So it's not just here's a recipe, hope you use it someday. This is a building that has our optometry and dental and so forth in it. Next. We have a lot of residential treatment facilities we do. So people with challenges who end up in an inpatient residential setting for a period of time. Next. All built with respect, honor, and beauty. Next. And then just to finish, we also have a whole wellness center. And this is if you want to learn from us, we have a whole consulting firm because people are interested in the 25 years of customer-driven design work we've done. Next. Just a tiny bit about villages. We support an area 2,000 miles end to end and 1,000 miles north to south, massive geography. And we operate and run all these clinics that are in these pictures. And then these are hubs, and then there's tiny clinics and little tiny villages around them. We have an entire workforce recruited from within the villages. So we have community health aides, community behavioral health aides, community dental health aides that are in the community. From the community, we support long distance. So there's a huge amount of design into the physical spaces and how we do use technology, but make it all welcoming and community-driven, community-based. Next. And this is the final thing. If we're successful, at the end of the day, this is what people say. They give me what I and my team have defined I need, when, where, and how I want and need it in a safe, effective, and optimized way. We weave ourselves into their lives on their terms, around their goals, their values, their aspirations. They really know me and care about me. They listen to me, advise me, support me on my entire health journey. My questions and concerns are answered. My care is coordinated. My values and goals drive my health plans. And this is, like I said, community drives program, program drives facility. We used to have only 15% of our workforce Alaska Native. We're at 65%, which means of our 2,500 staff, 1,500 are Alaska Native people. We encourage them to bring their lives and their families and their opinions and their lived experiences into the workplace and drive all of the work we do. People like me are just vessels and receptacles for input from community members and customer owners. And all we do is try to interpret and put in place what they want. And then continually, we spend 10 times as much on listening to the community as most people do. All of us in senior leadership spend 20 to 40% of our any time during their month. 20 to 40% is in the community, listening, connecting, responding, getting feedback. If you wait to design your space till you're ready to design your space, it's too late. You should be talking about spaces all the time. It should be a continual process, and you should continually tear down walls and rebuild walls and move things around to make things work for the people for whom we exist. And I think I'm finished. Next slide.
All done. Doug, that was amazing. Thank you so much.
Yeah, it's not enough time to really do justice. So if you want to know more, please contact us. We have websites. We have all kinds of consumer support, or customer support people to work with you. We do a lot of work helping people design spaces because we've become obsessed with this topic, and we do it pretty differently than most people do it.
Yeah. I will ask, I know that we have just a short amount of time left and we started late, so we will end around 8:05. But I just wanted to ask if there were any comments or questions for Carrie or Douglas today. And feel free to unmute yourselves to ask your question or post it in the chat.
I see in the chat box, somebody mentioned about local artisans. Our lobbies, we invite the community in. You can't, we don't sell like t-shirts and CDs, but people who do Alaska Native art, artisans can come in. We don't charge them. They set up tables, they sell their handcrafts and artists. You want it to be a bazaar. You want it to be a community center. You want it to be where community happens. And so that's also built into the space. Someone mentioned it in the chat box, and I think it's a super cool thing.
I think the other thing I also wanted to highlight is the fact that in doing this work and doing it with intentionality, it is really important to continue to speak to your community and continue to assess feedback, and doing that from the people, as opposed to doing it from the space of the people that work in that space. And I think that both of you did a really good job crystallizing that for us today too. So thank you.
I've got a quick question. This is Mike. I'm in Spokane. I'm a pediatric intensivist. This is awesome. I really appreciate the presentations. Both of the presentations represent what I would consider a frame shift from what traditional medical facilities do. And so as a physician leader, what advice do you guys have for a physician to try and convince the CFO, the CEO, the decision makers of an organization? I work for Providence, to invest in this. I mean, I have my own ideas, but I would love to hear from your experiences on that topic.
So the one slide that just jumped, my second slide would just jump through is, again, if you use examples like us and other places, it turns out if you do this better, you actually order less labs, less radiology, less pharmaceuticals, you refer less to specialists, your ER use rate goes down, your hospital days go down. So we've dramatically decreased all those things. So we invest, our human investment is about 5 times the usual amount. So our budget for primary care is, in terms of people, is very expensive, but our total cost is way lower than national averages because we refer less to specialists, less ER, less hospital days, less lab, less radiology, less pharmaceuticals, because relationship and encouragement and coaching and advising and partnering and being available all day, every day is a replacement for all that high-tech stuff, which is a replacement for actually knowing people, walking with people, and partnering with people. So our per capita spend is about 2/3 the national average, despite the fact of a very high-risk population. So we should be 3 times the national average. Instead, we're 2/3 the national average in terms of per capita cost. And the number of people we need to recruit and retain, and the hard to recruit and retain specialties and subspecialties, is way less by running the whole system this way. So it turns out if you give up revenue at a slower pace than you reduce cost, your margin actually improves, and healthcare doesn't seem to understand this. They think the only way to improve financial performance is higher speed, more processing, more work units, and increase your revenue, which is baloney. Everyone knows there's a lot of waste in medicine. So we think we reduce our costs by about 40% by how we do things, but we give up about 30% of revenue we could be making. But as long as your costs reduce faster than the revenue you give up, your margin improves, and CFOs like that. But it's a hard sell. It's not the medical model.
Pamela, you have a question.
Yeah, hi, I'm Pam Laborde. Thanks. I did a month in the ANMC in December in the early 90s, and that's a huge improvement. My question is, how do you deal? I love the open concept. I love the design, but I was wondering, for myself, I sometimes have to get away and be alone so that I can do the thought work that I need to do or some research that I need to do. And I sometimes have to do that in real time, just for my own concentration ability. Do you have any spaces built in that are easy to access for that? Because sometimes I just need to not be interrupted in order to complete my work. I'm wondering how you deal with that, or if you've had feedback on that.
Yeah, of course, when you have large integrated care team environments, that is the issue or the challenge that everyone brings up. So unfortunately, it's not a 1-minute answer. There's about a dozen different ways it's done. But yes, I mean, all the talking rooms can be used by staff anytime they need. They're not just clinical encounter spaces, they're also staff spaces. There are tables and chairs scattered all around in front of windows and places where you can go. And then a lot of people just put headphones on. I mean, just like on an airplane, you put noise canceling headphones on when you want to watch a movie, it's the same thing. And then we have tons of sound muffling devices built into our spaces and so forth. So the big integrated care team spaces are actually more like libraries than party rooms. And that's a lot because of the specifics of how they're designed. But sometimes you just need to go get a talking room instead of staying at your desk. That's the short answer. There's a long answer.
I will make space for one final question, if there is one, before you close. And Carrie, I wasn't sure if you had wanted to add.
Peter, I have one. I put it in the chat, but Doug, I don't know if this might be quick or long, but you commented on use of resources changing with the spaces, and I was wondering if you can comment on proportions of patients that keep their appointments, because I think we all know that patients that are potentially in some of our less wealthy groups, et cetera, get pigeonholed as patients that won't keep an appointment. And we know that no keep rates are higher. Has this changed?
The number one reason for missing appointments is delay from the time you needed something until you get something. And so the more you can provide immediately what people want and need, the more they are available. The real problem for showing up is created by us. So if we make people leave work, drive across town, wait in our waiting rooms, get naked, sit at an exam table, by the time they see us, they expect a lot of labs, x-rays, and pharmaceuticals because they've spent half a day, they've gotten off of work, they've done transportation, they need all these things by the time they see us because they've got this massive investment. If instead they can text or phone or email whenever they want to about anything they want to, and they can get a response right now, like within 5, 10, 15 minutes of when they have a need, they're still present. So the no-show rate, more or less disappears because it's our job to be available when, where, and how they want and need us. It's our job to weave our services into their lives at their convenience. And as soon as we make it about us and our convenience, and then we call them non-compliant for not doing what we ordered them to do and not showing up in our facility on our term, we're the most demanding, egocentric, narcissistic, paternalistic assholes on the planet. Modern medicine has taught us to be that way. And it's just wrong. They are living their lives. When they need or want something, it's our job to be immediately available by whatever form they want to communicate to us. Sometimes it needs to be in person, but most of the time, if you have relationship and trust in place, you don't have to make them come to your institution. I mean, just think about this. You're forcing them to wait, usually days or weeks. Then you're forcing them to come to your place on your terms, on your schedule, at your convenience, and then go through a ritualistic process that's offensive. And then you judge them for not showing up for their appointments. How paternalistic and judgmental.
With that, Carrie, actually, I was going to let you.
No, I think, Doug, your organization is amazing in terms of all the different things that I've heard from patients and families and communities across the country, and getting that flip of the switch to begin to understand their needs. And one of the things that I would suggest is just listening to your families and your communities and asking them even simple questions. The floodgates open at some of those barriers that come up, and it even it allows you to even have that insight in how to serve them better and figure out what's really maybe causing some of those discrepancies in their care. And it's just so important to listen and ask questions and be open to that feedback. And I want to learn more about your facility, Doug, and the processes that you guys have gone through. It's amazing. Really, really amazing.
Well, and we want to thank both Carrie and Doug for spending the time to sort of talk with us this morning. We knew that this webinar would generate a lot of buzz, just because it is something that is outside of a lot of our providers' wheelhouse, and it is also a major point of advocacy as we work to support our families and patients and communities better in this hopefully new age of medicine. So we are really, really grateful that both of you could bring your perspectives to the conversation today. And certainly if people have additional questions, they can reach out to us, and we are happy to connect you with Doug and Carrie as well after this talk. We want to thank all of the people that joined us on this webinar this morning. There were so many of you, and we really, really appreciate that. We also want to let you guys know that we posted the link for registration for webinar 3, which is providing safe and effective care, as well as we posted in the chat the survey to give us some feedback on the webinar. We know that it's only an hour long, and we could talk about any of these topics forever. So these are all starting points for generating conversation amongst yourselves as colleagues, but also with your organizations to make impactful change that really supports our families and communities. So with that, we just want to thank you all for coming, and we will see you in September. And that's it. Thanks, guys.
Thank you all.
Thank you.
Bye.